Good evening. I hope that you can all hear me okay. Welcome to Together Facing GYN Cancer. I want to thank all of you for joining us this evening. I'm Dr. Christina Chu. I'm a GYN oncologist and the interim chief of the Division of GYN Oncology here at Fox Chase Cancer Center. Tonight, my colleagues and I are going to share the latest in research and development and support services and more. Throughout the program, please feel free to leave questions in the chat feature on Facebook. We will be opening it up to Q&A later this evening. Before we kick off, I just want to take a minute to honor those of our loved ones who we've lost to cancer. Please just join me in a moment of silence. Thank you very much. I just also want to thank our exhibitors for this evening. It's really because of their generous support that we can offer this free program to you tonight. First, our gold exhibitors, Caris, Foundation Medicine, and Tempest. Our silver exhibitors include Clovis, Eisai, GSK, and Genmab. And also, I absolutely want to give thanks to our patient advocacy groups, many of whom you are familiar with: the National Ovarian Cancer Coalition, Unite for Her, and the Sandy Rollman Ovarian Cancer Foundation as well. They do tremendous work, as you guys know, in the GYN cancer community, and we're really grateful to have their support for our program tonight. So let me get things started. I just want to introduce, I'll go through the colleagues one by one and I'll introduce them and give them a chance to talk to you a little bit tonight. The first person I want to introduce is Dr. Stephanie King, one of our busy GYN oncologists. She's going to talk with you a little bit about GYN cancer screening, prevention, and things to look out for. Stephanie?
Thank you, Christina. So I've been given the job of talking to you about screening and early detection of cancer and cancer prevention. This is a very important part of our job. If we get out there, all the screening tests that we have to the populations that are at risk, and even those that aren't at risk but just develop the cancer spontaneously without any predisposing factors, then we've really done a good job. So all of you know, I'm sure Pap smears have been around for many, many years, and it was always drilled in our head that you have to get a Pap smear every year. Well, more recently, those screening recommendations have actually changed, because a good screening test has to be able to pick up disease before symptoms and before it becomes a more advanced problem that is more difficult to treat, but it also has to do less harm. So what we were finding with doing Pap smears every year from the age of 16 to 25 is a lot of young women were being exposed to the HPV virus, which is really the cause of most cervical cancers. And what was happening was we were doing a lot of unnecessary procedures on young women who, by removing portions of their cervix to try and prevent an invasive cancer, we were actually causing a lot of premature deliveries and a lot of unnecessary premature deliveries. Because what we found was that if we wait until a woman is 21, where she's probably been exposed to the virus, been able to mount an immune response in her body, get the virus under control, then she doesn't necessarily need to have that procedure done, and then she can not have that exposed risk of having a premature infant, which is a very difficult thing. So again, a good screening test is something that will pick up something in the population before a symptom occurs. Again, another good screening test, not so much applicable to GYN cancers, but mammograms. Everyone is encouraged to get their mammograms after the age of 45 and 40 to 45, and then yearly thereafter. So again, but so we're not really talking about breast cancer, but that's another good example of a screening test. So screening tests are very important, but the rules sometimes change. So it's important for you to have that discussion with your practitioner, your gynecologist, as to when those types of cancer screening things change, okay? So, so we talk about prevention also. So prevention, what can we do to prevent cancers? Well, Dr. Rubin's going to talk to you a little bit later about genetic testing for cancers. And if we do find a genetic predisposition to certain cancers, then we often recommend prophylactic removal of an organ, such as your ovaries or fallopian tubes, to try and prevent that from occurring in the future. And that's more directed for a high-risk population. But in a screening thing, you're just really screening the general population. So other things are, some cancers don't have a good screening test at all. So ovarian cancers, fallopian tube cancers are prime examples of that. These very nonspecific symptoms, abdominal bloating, not feeling, just having gastrointestinal distress. And a lot of these things are very common in women, especially premenopausal women. But postmenopausal women develop these symptoms. It's kind of something you need to be aware of. But even if you go, when you have these symptoms, we have a more advanced cancer. The goal is to pick up a cancer treatable. So again, there's things to look out for. Another cancer, endometrial cancer, has an early warning sign. So be very proactive if you develop postmenopausal bleeding. If you're after the menopause and you develop bleeding, see your general gynecologist, because the onus is to make sure that we're not dealing with a pre-invasive or invasive cancer of the uterine lining. Again, endometrial cancers do pretty well because a lot of them have the early warning sign, and women go and get taken care of right away. So I don't want to go over my time, Christina. What do you think?
I think that sounds great. And hopefully we'll get some questions in the chat for you. Thank you, Dr. King. Next, I'm going to introduce Dr. Stephen Rubin. He's going to talk with you another one of our busy GYN oncologists, to talk to you a little bit about hereditary cancers.
Well, good evening, everybody, and thank you for joining us tonight. Hereditary cancers are an area where there's been just an explosion of knowledge in the last 10 to 20 years, and I think an explosion of interest also among patients and providers alike. Most of what I'm going to say tonight will apply to certain gynecologic cancers, including ovarian cancer and endometrial or uterine cancer. Cervical cancer, which is our third most common cancer in gynecologic oncology, really does not have a hereditary component, so it will not be relevant to this discussion. And a lot of what I say will also be relevant to breast cancer and colon cancer, and you'll see why shortly. I think the first thing to remember is 85% of these cancers have nothing to do with heredity. That leaves about 15% that do. So 85% are what we call sporadic. They occur as part of normal wear and tear on our normal genes. Cancer, whether it's sporadic or inherited, is a genetic disease. You can inherit normal genes from your parents, but if you get a certain number and type of abnormalities accumulated in your genes over the course of your lifetime, you may develop cancer as a result. And that is what happens in these about 85% of sporadic cancers. The other 15% roughly are hereditary. This means you have inherited an abnormal cancer predisposition gene from one of your parents, and these can come from your mother or from your father, and there's an equal possibility of both. And having one of these mutations or abnormalities in a cancer predisposition gene puts you one step closer to developing cancer. So some of the common ones you may have heard of include genes like Brca1, Brca2, and so-called Lynch syndrome genes. These are genes involved in DNA repair, and if you inherit a damaged DNA repair gene, then you're more likely to get cancer, and in some cases, very much more likely to get cancer. For example, let's talk for a moment about women say, who inherit Brca1 mutations. In the average population, the risk of breast cancer is about 10%, and the risk of ovarian cancer is 1% to 2%. If you have a Brca1 mutation, your risk of breast cancer is 80 to 90%, and your risk of ovarian cancer may be 30 to 40%. And there are increased risks of other kinds of cancer as well. If you inherit an abnormality in a Lynch syndrome gene, you have a greatly increased risk of both endometrial cancer, ovarian cancer, and a number of GI cancers. So these come from either parent, as I say. If one of your parents is a carrier of one of these abnormal genes, you have about a 50% chance of inheriting it, as do your siblings. And nowadays we have really miraculous genetic testing that can peer into our genes and identify these risks. So Fox Chase has a world-class genetic testing service. It recently celebrated its 25th anniversary. It's one of the oldest and best in the country. And we send a lot of patients for genetic testing because there are tremendous benefits. There are benefits to your family members who may be concerned about their own risk if you have one of these cancers. There are many things that can be done for high-risk women in terms of screening. They can have enhanced breast cancer screening, for example, with breast MRIs and mammograms. They can have preventive surgery. Women can have their tubes and ovaries removed as a simple outpatient procedure and eliminate the risk of tubular ovarian cancer. And if they are people who do have one of these cancers in association with a mutated cancer predisposition gene, this opens up additional treatments for them. They may be candidates for targeted treatment, or they may be candidates for immunotherapy. So it's critically important to get this testing when it's indicated. And we now recommend it for all women with ovarian cancer. As I am fond of saying to patients, knowledge is power, ignorance is not bliss, and what you know can hurt you. So if your doctor recommends these, I would get them. I can tell you my family has been tested and it's been very helpful and worthwhile. So I'll stop there and look forward to questions later on.
Great. Thank you very much, Dr. Rubin. So these have been a great introduction so far. We're going to move on to just some introduction to treatment kind of issues. And so the first person I'll call on is Dr. Angela Jane, one of our medical oncologists who specializes in GYN cancers. She's going to talk to us a little bit about some of our newer immunotherapies and targeted therapies.
Hi, everyone. I'm Angela Jane. I'm the Chief of GYN Medical Oncology here at Fox Chase, and it's my pleasure to talk to you today about some of the newer therapies that have come out. You know, when I think back to treatment 10, 15, 20 years ago, we talked about offering patients surgery and chemotherapy and radiation. And, you know, about 10 years ago, we had the first targeted drug really come out in full force in ovarian cancer, a drug called bevacizumab or Avastin. And this completely changed the world as we knew it in gynecological cancers, as this is a drug that really improved the quality of life for our patients, not just because it helped us to avoid chemotherapy side effects, which it does, but it also had other benefits in not just controlling the disease, but helping with specific issues like fluid that some of our patients get. And I'm sure many of you that are out there today have heard about this drug and have probably even received it. And you know, that was the first of many to come. And this drug has now, you know, we now use it not just in ovarian cancer, but we use it in endometrial and in cervical cancer. You know, and so many of you may be talking to us about using Avastin as an alternative therapy or in combination with chemotherapy at some point. It's an infusion that is given through the vein or through a port, but it doesn't come with the side effects of hair loss and neuropathy. It has its own set of side effects that we worry about. And, you know, of course, we would talk to you about all of that, you know, when we're with you in the office. The next set of drugs that came to ovarian cancer treatment is a set of drugs called Parp inhibitors. What was new about this set of drugs is that it offered pills instead of an infusion. And what was even more amazing about this set of drugs is initially it came out with the approval for patients with a Brca mutation. And this allowed for us to really start to personalize medicine in gynecological cancers and more specifically in ovarian cancer. But over the past several years, and especially in 2016, Zejula or niraparib became the first of 3 Parp inhibitors. Later, Brca and Lynparza all became approved for maintenance therapy in ovarian cancer. And a lot of you with ovarian cancer, with the more traditional high-grade serous type, have probably heard us talk about these drugs to you, and using it as a maintenance therapy, potentially as a treatment therapy. Again, this is a pill, not an infusion. Was the first of targeted therapy pills that came to ovarian cancer. What has also come in ovarian cancer is a new targeted therapy that we are using for a less common histology called low-grade ovarian cancer. This tends to behave and act differently from the more common kind of ovarian cancer. And there's a different pill called trametinib that we're using now in that cancer. And that's a clinical trial that showed that this drug was helpful in this very specific population. And so it's another treatment that we might talk to you about in the office. For our patients with endometrial cancer, 2 major advancements have come out in the past 3 to 4 years. The first one was the advancement of immunotherapy coming into endometrial cancer. Initially, we thought it was just for our patients with Lynch syndrome, which Dr. Rubin was just speaking about earlier. But more recently, we can now offer immunotherapy with an adjunct pill to all of our patients with metastatic endometrial cancer. Not quite there yet to know that immunotherapy will help all patients with endometrial cancer. And so this is something that we're still researching. Clinical trials are ongoing to look at that. Unfortunately, immunotherapy hasn't found its way into ovarian cancer treatment yet. And those are clinical trials that are still ongoing and running that we're happy to talk to you about. And Dr. Maldonado will talk a little bit more about that in a little bit. The other advancement that we have been watching in endometrial cancer is, sometimes we'll use molecular testing and genetic testing of tumors to help us understand these tumors better. And we have found that sometimes there's a breast cancer drug called Herceptin that we have started using in specific kinds of endometrial cancer. That's something, that we would talk to you about in the office, as these are all approved treatments. The newer kid in gynecological cancers is actually a treatment in cervical cancer, hot off the press, literally just FDA approved about 2 months ago, or no, actually last month, is a drug called tisotumab. And this is specifically for women with metastatic cervix cancer. It's the first new indication in cervix cancer in years, and we're just delighted to see that we are moving the line, and we are moving things forward. And many of you, out there may have been a part of these clinical trials that have brought these drugs to light, and we thank you for being a part of it. And some of you may be a part of future clinical trials. And Dr. Smaldone in a little bit will talk to you about what that process might look like. So thank you for coming today, guys.
Thank you so much, Angela. Next, I want to introduce Dr. Gina Maldonado, one of our GYN oncologists. She's going to talk a little bit about some of our clinical trials that we have.
Thank you, Christina. And I appreciate everyone's time tonight. We look forward to the Q&A session to answer any questions regarding the topics discussed. I'm very pleased to present about clinical trials. This is very near and dear to my heart. As it is a main research interest. We are always looking out to see what the next best step is for our patients. Clinical trials are the way that we can improve upon not only prognosis, but quality of life for our patients. As a GYN team here, we meet on a monthly basis to go over open trials that are here at the site, but also to look at new opportunities to either partner with industry or with the NRG oncology, or to look at opportunities to develop investigator-sponsored research trials. As you meet with your provider, we often will go through standard of care options, and as Angela Jane had just mentioned, that some of these targeted therapies were investigated in a clinical trial are now standard of care. So we use evidence-based research to determine the best care for our patients. And in order to improve upon what we already know, we look at these clinical trials as an opportunity to look at new agents or new mechanisms to target the cancer so that we can improve prognosis and quality of life. When you meet with a provider, often they'll go through whether it's a phase 1, 2, or 3 trial. And these are very common topics that you may have heard about, but just to briefly review, a phase 1 trial is really gaining some information about a safety and the dose of a new medication. It may have been studied in another disease site, but we are looking at it in particular gynecologic cancer and looking to see if it's safe, but also to determine what the tolerated dose is so that we can move on to a phase 2 trial, which is going to look at how effective it is in treating our patients, versus a phase 3 trial where we're potentially comparing it to what's considered standard of care for that disease. In the GYN team, we look at phase 1, 2, and 3 trials. We also look at the different diseases that we treat for our patients and look to see what we can offer. We have trials that are focused on interventional studies, looking at new agents. We also have options for participating in preventative studies. I'm very excited that we'll be opening up a NRG study, which is looking at prevention of ovarian cancer in BRCA1 carriers. And the idea of this trial will be to look at improving quality of life for our patients. As many are aware, preventative strategies for ovarian cancer, our best way is to take out both the tubes and the ovaries during surgery. And a lot of women at the time of the surgery are premenopausal. Doing this surgery induces menopause immediately and has a lot of short-term but also long-term impacts. This NRG study will be looking at whether it is safe to remove just the fallopian tubes for prevention, and later on go back and take the ovaries out when women are closer to menopause. This is an investigation that has been studied in a smaller study among 6 sites, and this will be an international and national study that will be conducted here as well as in other institutions. But we're very excited to offer this as an option for patients. And the idea is to help improve upon the knowledge that we have. How do we improve the quality of life of our patients, and how does this change the cancer prevention and potentially other risks such as breast cancer? So we're very excited to have that trial opening soon. We also have options in ovarian cancer for targeted therapy. There is an antibody drug conjugate known as mirvetuximab soravtansine, which is targeting folate receptor alpha in women with ovarian cancers. Particularly the trial we have open right now is looking at women with platinum-resistant disease. And hopefully we'll be having a trial available for patients with platinum-sensitive disease. But basically now we can target the tumor to look and see if this marker is present. It's called folate receptor alpha. And then if patients meet a certain eligibility criteria, they may be able to participate on the study in those two disease settings. We are also looking at opportunities to partner with the NRG to improve upon women in the frontline setting, as well as in platinum sensitive. So I'll have to keep you updated on that. But when women present with ovarian cancer or patients who are at risk for ovarian cancer, we'll be mentioning these trials and investigating whether these are great options for our patients. For endometrial cancer, we are also looking at targeted therapies. So there is a clinical trial that's looking at the utility of Parp inhibitors in women with endometrial cancers that may have had advanced stage or recurrent disease. And it is a randomized trial looking at rucaparib versus placebo and trying to see if we can keep women in maintenance therapy that would keep them in remission longer. So this is an option for our patients as well. As Angela also mentioned, the TVAC that was just FDA approved, we participated on that study for cervical cancer patients. So we're very pleased to know that it's now FDA approved, another option for our patients. And, you know, as a group, we're always looking out for the next options. Many of us participate on the NRG of oncology subcommittees in the ovary, uterine corpus, cervical, phase 1. So we're always trying to keep up to date with the best knowledge that we can present to our patients. So we offer you the opportunity to discuss these when you meet with us and to see if these are good fits for you. I really appreciate everyone's time and I look forward to the questions in our Q&A session. Thank you, Christina.
Great, thank you, Gina. Moving on with our sort of treatment focus at this point, I want to introduce Dr. Krisha Howell, who is our GYN radiation specialist here. She's going to talk to you a little bit about radiation options for the treatment of GYN cancers.
Thank you, Christina. Good evening, and thank you for joining us tonight. So the first thing I want to say is I'm representative of Fox Chase Radiation Oncology GYN team, but I am one of a few providers that also serve us at East Norton and at Buckingham. And then also a dedicated staff that does include nurses just dedicated to brachytherapy and our patients on treatment, along with our patients being seen in consult and follow-up. So we have a very robust staff that is there to help support our patient population and our survivors who we see in follow-up. So first of all, I think something that has changed since we've been involved in cancer care is how well our patients are doing. And so I have to recognize that radiation is a component of our patients' care and that we work as a team. And I think here at Fox Chase, we do that very well. So we come together typically once a week and we discuss relevant patient cases. We discuss our roles as radiation therapists, surgeons, medical oncologists, and others, and how we fit into the patient's bigger picture. So my role is not only to deliver radiation therapy, but to deliver radiation therapy in context of the patient's personalized needs in cancer and their other needs. We have seen patients that may want to retain fertility. They may have had previous treatments, only one kidney, issues with dialysis. We realize that all these are challenges or things that we have to accommodate within their treatment. And we do our best to do that for the patients. So types of radiation could be external, meaning the radiation is given from the outside of the body, directed inwards. I tell patients this feels a lot like getting a chest X-ray or a CT. You can comfortably receive the radiation just lying on the table. This is usually administered daily for multiple weeks, and we would check up on the patient at least once a week. Another means of delivering radiation would be brachytherapy, or giving the radiation from the inside directed to the tumor. So we would implant either with a Tandem ring, needles, or a cylinder. And so that would go into the area at need. And that would be administered usually one time or a few times. And we would work with the patient to customize that to what was needed for their cancer. And I will stop there. Thank you again for joining us tonight.
Great. Thank you so much, Dr. Howell. I want to move on from our physicians to the rest of our really integral team members. Krisha had talked about how important it is to have a team on your side. And so I'm going to introduce some people who are really, really key to taking care of you all, taking care of patients here that we just could not do without. First, I want to introduce Kathy Smith, who is our chemotherapy nurse practitioner. And she's going to talk a little bit about a topic that's really near and dear to all of our hearts, which is survivorship.
Thank you, Dr. Chu. As Dr. Chu said, my name is Kathy Smith. I'd like to welcome everyone to the Together Facing Gynecologic Cancer program this evening. I wanted to talk a little bit about survivorship. And oftentimes, patients will ask, when does survivorship start? And really, survivorship starts at the time of your diagnosis, and it lasts throughout your life. Survivorship care focuses on your past diagnosis of cancer. It can address any lasting side effects from treatment, whether from chemotherapy side effects or side effects from radiation or even surgery. It's also preventative care to help improve your quality of life, help improve your future health. Many cancer survivors will go on to live very healthy and active lives after treatment. And we want to support them and help them through this time. Some of the benefits of survivorship care is that it's a medical care that's focused on the individual survivor. So there can be education on issues and needs during the life of your treatment, during life after treatment. It's coordinated care, and it incorporates your cancer doctors and your other healthcare providers, whether it's primary care doctors, a cardiologist, whatever your individual needs are. And then, so who provides this care? We have a survivorship clinic that, or your oncologist can do as well. But it's someone who has expertise in your specific type of cancer. And they can perform physical exams, diagnose and treat illness, order tests, make referrals, write prescriptions and that sort of thing. Your doctor would still be, your cancer doctor would still be, overseeing your care, but they would help. But the Survivor Clinic could help support you in surveillance after your treatment. So Survivorship Visit would be include like a medical history and physical. It would gather your test lab results, test data, go over all of that with you. It's looking for surveillance for any return of cancer, looking for late side effects, also counseling about genetic risks. If there's anything that was identified, there's counseling for that. There's also education about healthy living and wellness, some of those aspects. There's advice on screening tests. It's maintenance care, wellness, when you're due for, say, your other health maintenance things, whether it's mammogram, DEXA scans, routine surveillance. So it kind of gives coordinates all of your cancer care. And it's developed into a care plan. And I would just like to say on a personal note that I've worked with cancer patients and cancer survivors over the years, and I continue to be in all of you. It's your strength, your fierceness, your endurance, and your flexibility to bend and your unwillingness to break that inspires me every day to do what I do. So thank you for having me tonight.
Thank you very much, Kathy. You talked about, the importance of health and wellness. And so the next person I want to introduce is Tara Mora, one of our nutritionists, which, such a huge topic, I think, for all of our patients, not only for general health and wellness and cancer prevention and good living, but, nutrition is so important during treatment as well. So Tara, please take it away. Thanks.
Thank you so much, Dr. Chu. I'm so happy to be a part of this event tonight because, as Dr. Chu mentioned, I believe that nutrition is so very important for all cancer patients, specifically our GYN cancer patients. We've learned a lot about different treatment options, and regardless of what your treatment path is, optimizing your nutrition throughout treatment process, maybe beforehand, during, and even after, is very important. Maintaining your strength, and just feeling well. It makes such a big difference, and that's why I really enjoy working with this population. Some patients might start off their diagnosis just from different symptoms. Maybe you're feeling full more quickly. This can often lead to weight loss, and working with a dietitian is helpful to prevent any further weight loss, help to maintain your muscle mass and your strength, and to carry you and support you throughout the rest of your treatment and into survivorship. And while every patient is different, I think that's why it's so important that each patient does meet with a dietitian and review different things like food allergies and food preferences and cultural and religious preferences, and to help you to identify what will work for you, what will work for your schedule and for your routine to help to support you through treatment and into the survivorship process. So I am looking forward to questions during the Q&A session. So thanks again for having us.
Great, thank you so much. And the last but certainly not least member of our team that I want to introduce is Joanne Ruffo, who's our social worker, who many of you also may know. She's going to talk to you a little bit about support services that are available, and it dovetails very nicely into one of the very first questions that we got submitted. An audience member had asked, given that being diagnosed with cancer can be overwhelming, what support systems does Fox Chase currently have to help patients in this difficult time? And I know that Joanne's got an answer to that.
Thanks, Dr. Joe. Hi, everyone. I'm Joanne Ruffo. I've been with the social work department at Fox Chase for many years. And just to echo everyone else, I'm really glad to be part of this event tonight and to speak to all of you. And that question sort of sums it up in a nutshell. It's an overwhelming experience. And so we're all here to try to help you through that. And to toot the horns of social workers, I can tell you as one of several at Fox Chase that I think we're a great place to start in terms of figuring out where to go next to try to help you through all phases of your cancer, you and your loved ones. So no matter where you might be in your experience, I would encourage you to reach out for assistance and support at any time that you think it might be needed. And a lot of times what we talk about with people that we might encounter, patients or their loved ones, is that sometimes they don't know where to go next. And so sometimes we say, start with us. And if we can help you get to the right person on the team or someone else in the institution, we will do our best to do that and to advocate for you. But some of the support services that are available at Fox Chase to help people with a cancer diagnosis. So a social worker, like what I do, can offer counseling support just to help you deal with the various emotions you're dealing with this diagnosis. We also can help you figure out what other resources for support might work for you. It can be a pretty personalized thing of how people deal with this. So it might be maybe connecting with other services, such as at Fox Chase, we have something called the patient-to-patient network, which can match people with someone, a patient or also caregivers with someone who's gone through a similar experience and can hopefully provide you some added insights for some one-to-one phone support. We also can help, a social worker can also help sometimes figure out if you should be or need to be connected with maybe additional mental health services to help you deal with some of the other issues that come along with a cancer diagnosis. We have a great psychiatry program here, psychiatrists and psychologists and nurse practitioners in that program that can help us with medication management and stress management techniques, and can help the rest of us as a team, the GYN team, help you deal with this disease and all the myriad emotions that might come along with it, and also just dealing with some of the side effects of treatments, fatigue and whatnot. And then also we can help figure out, a lot of times there's a lot of other things out there in the community. So a big part of what a social worker can do for support services is figure out, okay, what else is out there? What other groups are out there? What other resources? And so sometimes that's a more practical purpose, help figure out if you need transportation help or financial help, but also other support resources that might better meet your needs, or just meet your needs beyond what Fox Chase might be able to offer you in terms of services for yourself or your family members or other loved ones. And the other thing I would say is just to say that we also recognize that we're encountering you as the patient, the quote unquote patient, but we do all try to remember every single day that you're a whole person and you're not just this person who's coming in our door as the patient, and that there's all these other parts of your life that are even more important to you. Your health is of course paramount, but other parts of your life that are incredibly important to you. And so we are trying to help you maintain your life as best as possible and support you through this part of your life. And thank you.
Thank you so much, Joanne. So now we're going to open it up to the audience for questions. Please feel free to drop a question in the chat function. And please be assured, if we don't get to your question tonight online, we will definitely be following up with you after this evening concludes. We promise that every question that goes in the chat, we're going to have an answer for. Okay, so let me see, we received several. Why don't we start with one? One audience member has asked, has there been any progress on development of an early stage ovarian cancer screening test? And that's going to dovetail into some questions about the Grail test, some cell-free DNA testing, but maybe I can ask Dr. King or Dr. Rubin if they want to chime in about that.
Christine, can you repeat the question? I'm sorry.
Sure. Has there been any progress on development of an early stage ovarian cancer screening test?
I don't know of any that, I mean, again, ovarian cancer is a very difficult cancer to pick up early because of its myriad of symptoms that mimic a lot of other GI disturbances and things like that. And the CA125 and the ultrasound have been the mainstay of trying to develop, looking at imaging studies or blood tests that are picking this up earlier. But as far as I know, no. What do you have anything, Steve, for that?
I agree totally with that, and it's not for lack of trying.
Yeah.
Ovarian cancer screening with CA125 and ultrasound has been studied for about 30 years in huge trials, tens of thousands of women followed for decades, both in the United States and in the United Kingdom. And all these trials have come up empty-handed. And that kind of screening just doesn't work. And there's really nothing better on the horizon.
Great, thank you. The next question that we received kind of goes along with that a little bit. Do the doctors at Fox Chase recommend patients get the Grail test? And if yes, is this something that I can have done at Fox Chase? Does anybody want to have an answer for that? Maybe Dr. Jane, or I can speak to that. For patients and those of you who aren't aware, the Grail test is a blood test that looks at something called cell-free DNA. So some patients may have little bits of cancer DNA floating in their bloodstream that some tests hope to pick up and perhaps diagnose cancer early. And the Grail test is a test that is not exactly been FDA approved, but it's been approved by the FDA as a new technology. So it's being marketed by the company that does it as a way to try to help identify a panel of cancers. Now, it's not something that any lab can run. It's a proprietary test. So basically you have to apply to the one company that does it, send blood off there, and you have to pay out of pocket for it. So I checked on the website today, the cost is about $946 for the test. This is not something that insurance covers. And it may cover a panel of cancers, but not anything with the accuracy that any of us would be happy with. So it's definitely not a test that is widely used or even recommended by us as physicians here. So I hope that's an answer to that question. Do you guys have any other comments that you'd want to make about that?
No, Christina, I completely agree with you. I think that we just, we are very hopeful that this technology is going to continue to advance and help us with early detection, screening, and potentially help us with treatment making decisions in the future. I think we're not there yet, but hopefully one day.
Great, thank you. And another question briefly went along with this. Someone wrote in and said, I saw Signatera on Facebook. If I understand it correctly, it stated that this was used to diagnose recurring cancer. Is this a blood test? Is it new? And is it used at Fox Chase? Anybody want to comment on that one? Sort of similar idea of cell-free DNA. It's
a similar test that's looking for, the DNA of cancer cells within your blood. And, with the idea that can it help to detect a recurrence of your cancer. So you've had cancer and using it to see if it has come back. In ovarian cancer, we know that this is not a cancer that always uses the bloodstream. And so I think we have to be very cautious in making sure that we use these tests for the right patient. And so, that's where, it's on me, Dr. Chu, Dr. Rubin, Dr. King, Dr. Smaldone, to really help you understand if this is a test that you need. I think we're just not there yet.
Great, thank you. I think the most data that there is, which is already kind of scanned, is for colon cancer, lung cancer, bladder and breast cancer. So there's not a lot of support for its use in our GYN tumors. Great, thank you. So I want to move on a little bit from sort of screening and surveillance to another question that someone sent in. And it said, are there any new clinical trials with inhibitors or I guess treatment for low-grade serous carcinoma? Maybe Dr. Maldonado, could you speak to that?
I think overall clinical trials focusing on this type of ovarian cancer are very challenging. It is a more rare form. So a lot of times the trials that are being conducted are done through collaborative groups like the Energy Oncology, where really it's going to be partnering with multiple institutions to really get the most information that we can better prognosis and treatment for these patients. A lot of the clinical trials are looking at the tumor milieu, looking at whether there's hormone receptor positivity to target that in combination with other agents that may inhibit the cell cycle. A lot of times these trials take many years to accrue, even get approved by these national groups. We don't have any current trials that are targeted there yet here at our institution. I don't know, Angela, if you wanted to comment any further.
Yeah, I agree with you, Gina. I think, we do know that some low-grade ovarian cancers do respond really well to chemotherapy. So don't feel that, if you're doing some research that chemotherapy would not work for you. It does work for many. We also sometimes think about using anti-estrogen-based treatments. You might hear about a drug called tamoxifen or another set of drugs called aromatase inhibitors. And these are anti-estrogen-based treatments that there have been clinical trials that have been done and published that show that these drugs can be helpful and work. Earlier, I had mentioned about other new pills called Preventative that clinical trials in the past have shown can be helpful in low-grade ovarian cancer. And so it's a group of patients that, as you might know, it's a less common histology, and so getting clinical trials done to help women with this type of ovarian cancer takes a long time to put together, but slowly different concepts keep getting discussed at our national meetings. I know Dr. Smaldone at a meeting about a year ago had proposed a study. And so, we continue to look for better treatments, but I do agree with Dr. Smaldone, there isn't a specific study open right now.
Great, thank you very much. Let's move on to a little bit of a different topic. And here's a question that we received. Is there any new research on ways to reduce recurrence, particularly for endometrial cancer? And I think Dr. Jane, you had touched on that briefly, a little bit about clinical trials, and maybe Dr. Maldonado as well. So would anyone like to address that?
Reducing recurrence in endometrial cancer is a tricky subject. We haven't really hit the nail on that just yet. So, part of our job as your doctors is to help make sure that we know when treatment is worth it for you and when it's not worth it for you. And, sometimes in thinking about the side effects of some of these drugs, sometimes, in the back of our mind is the balance of the side effects of the drugs, worth you being on potentially for months and years. And that's sometimes something that we balance. There are in endometrial cancer sometimes trials that do come along, and Dr. Smaldone, I don't know if you want to mention the trial that we have running.
Yeah, so I mentioned previously that we do have this clinical trial. It's looking at the use of rucaparib, which we often is one of the known Parp inhibitors that we use in ovarian cancer, but it's being investigated in women with recurrent endometrial cancer or in women with high stage tumor, stage 3 and 4, who have undergone their chemotherapy and now are looking at ways to utilize this medication to improve their remission rate. So it is a trial that is randomized to the rucaparib or placebo. It is being conducted at about 4 sites nationally. We're very excited to be participating in it, and we're hoping that we can continue to improve that knowledge for our patients. So it is definitely something that we bring up with our patients when they get to the end of their chemotherapy, and I would encourage patients to bring it to our attention if they're interested.
Great, thank you. Maybe the next question I'll throw to Dr. Rubin. Someone has written in, I've been diagnosed with ovarian cancer. What should my daughter do for prevention since this is not detected in her yearly exam?
Well, that's a good question that comes up often. As I indicated earlier, the national guidelines recommend genetic testing for all patients with a common type of ovarian cancer. So the first thing you ought to do is get tested for genetic abnormalities. If you have one of these abnormalities, and the chance of that is only about 15%, then your daughter or other children or other relatives may wish to be tested also, and they can get a lot of useful information out of that. If you are tested and found to be negative for these changes, then your daughter can relax and forget about the whole thing, because her risk of ovarian cancer would not be increased.
Great, thank you very much. Here's a good question that I'll address to the group. I think it's a big question. What determines the frequency of chemotherapy? No takers for that?
Well, to just talk briefly, I think a lot of the timing and the dosing we determine from clinical trials. We determine the dose and the safety based on defined criteria about the grade of the side effect the patient will have, and we look to find a safe dose, and the frequency of the dose is often part of a phase 1 clinical trial. So a lot of times the medications that we're using that are standard of care, the dosing is based on trial information that we have obtained over many years of study.
Great, thank you. So I have a question. I'm going to address that to Tara. A lot of my patients will ask me, particularly when they're finished with their treatment, you know, should I be doing a keto diet? Should I cut out sugar? What should I be eating to be healthier, to prevent my cancer from coming back? Is there something special I can do? Because I think people feel like that's something they can control, you know. So what would you say to that person?
Absolutely. So this is something that I get asked a lot, actually. Is there a special diet that I should be following? Because I am a cancer survivor and I want to, you know, reduce my risk of it coming back. And absolutely, you can make changes to your overall dietary pattern, but I wouldn't say that there's one special diet that all people should follow. There's lots of research out there that different foods should be avoided for, you know, increased risk of colorectal cancer, like red meats, processed meats. But really the best thing is getting a good balance of all nutrients. And that might look a little bit different for all people. But one simple way to try to do this is using the plate method. If you're familiar with or haven't heard of it, the USDA puts out the My Plate graphic, which shows a representation of what one plate should look like, including a source of lean protein, a nice source of whole grains, and including some type of fruits or vegetables at each meal. It's recommended that half, if not all, of our carbohydrate sources are coming from whole grains, which are providing our bodies with sources of healthy fiber, vitamins, and minerals, including more color as best as we can whenever we're eating. The more variety of color that we're getting from different plant foods, the more benefit we get from different things like phytonutrients, which we don't even know all of the benefits of. And so while a lot of these recommendations kind of sound generalized, that's why I think it is important for patients to meet with a dietitian so they can kind of work with you one-on-one to identify what will work out best for you, for your, you know, history of surgery or a history of intolerances, or maybe you're still going through parts of your treatment and managing those side effects. But overall, following more of what's called a plant-based diet, not necessarily eliminating all animal products, but making sure that more of your plate is more plant-based to get in all of the nutrients that we do need.
Great, thank you very much. We have another question in the chat, and I'll just open it up to the group. Are women with endometriosis more likely to develop a GYN cancer? It's a good question. Anybody want to respond to that?
We do know that endometriosis is an independent risk factor for ovarian cancer. There's a lot of chronic inflammation in the lesion environment that we think can lead to the promotion of cancer. Oftentimes we'll see that the type of cancer is either an endometrioid or even a high-grade serous histology. So it is something to be on the lookout for. And there are cases of ovarian cancer where in the tumor we can find deposits of endometriosis. The treatment, however, still stays the same for a lot of patients to the same standard of care, although some of the endometrioid type of tumors may be treated a little bit differently.
Great, thank you. I guess I'll throw another question to Kathy. You know, similar to, you know, patients who ask questions about their nutrition, you know, for Tara at the end of their treatment, you know, what advice would you give to a woman who's finishing up her chemotherapy or her radiation as, you know, sort of best tips for survivorship and for moving forward?
So I think at the end of chemotherapy for a lot of women, you know, it's a time when there's anticipation. It's a time where there's a lot of anxiety because you had this diagnosis and then you're going through chemotherapy. And although you may be having side effects from that chemotherapy, oftentimes women will feel, well, I'm doing something for this. And then at the end of treatment, it's kind of this anxiety. Where do I go from now? How do I start getting to feel like myself again? So I think, you know, maybe like a month to 2 months after chemotherapy, your blood counts are starting to recover. Your hemoglobin is usually getting better. You can, you know, and often during chemotherapy, your body's trying to adapt to changes in your blood counts. And so it's really those couple months after chemotherapy when you realize, oh, wow, I didn't realize that I felt so, you know, poorly until you start feeling better. But I think that those, you know, a month to 2 months after treatment, your hair is starting to grow back if you had hair loss. You're getting more energy, a little less fatigue, and starting to get back to those things that you like to do. Sometimes it means maintenance therapy after primary therapy. And so sometimes now you have new potential side effects that we have to manage and help support you with. But it's good to, you know, talk to your provider and, you know, try to look at these next few months as regaining, you know, healthy lifestyle, you know, making the referral. Sometimes people are really deconditioned after chemotherapy and they need help with physical therapy. So it's really going to be individualized to what your needs are to get you feeling better.
Great, thank you so much, Kathy. I'm looking at the clock and it's 7:31 now, so I think that's our time for the evening. I really want to thank our exhibitors, our advocacy organizations for all of their support. I want to thank you for all of my colleagues here for joining me this evening, and thank you for all of you who have spent time with us this evening, tuning in and asking your questions. Please be assured that if your question wasn't answered tonight online, we will be getting back to you offline with an answer to your questions. We promise to answer everyone. Just some other announcements. We're going to be hosting several virtual Together Facing events this fall. Our next one is going to be called Together Facing Lung Cancer, and it's going to be on November 9th. So if you or a family member or a friend, you know, are interested, please don't hesitate to reach out. It would be great. You know, we'd be really glad to give you the information for that. Please check our website, our Facebook page for more information. Okay. So you guys, thank you all again. Please enjoy the rest of your evening, and everybody take care. All right. Have a good night.